Yes.
About 15 minutes each. 15 minutes each. Is that what we're aiming for? I always set my stop clock. I set the stop clock. My phone clicks on. I know.
Sometimes it just
I'm
goes
going to have
into
to
a
punch in my
different
code,
page.
I guess.
Who said Lori's not here yet?
I don't think Lori is here.
He
was here this morning, actually.
Was he?
He was around this morning.
Oh, here he is. No. There's 3, almost.
Most GI. Yeah, Jennifer's probably finishing here, so should be a few minutes late.
Katrina, what's happening? Okay. Well, good morning, everybody. Welcome to Grand Rounds. Today's topic is advances in GI. Not sure that's got it correct. Yes, advances in GI. The first speaker is Dr. Rob Enns, the division head from UBC and St. Paul's Hospital, and he'll speak to us, I guess, first and introduce the other speakers.
Thanks, Barry. It's a pleasure to be here. Talk a little bit about advances in GI. I've always said that if you're not moving forward, you're likely moving backwards, since the tide is carrying one direction. So if you're sitting still, you're actually moving backwards, especially when it comes to technology. So we're going to try to outline 3 areas that we are making movement on and that we're really trying to emphasize over the next few years. It is critical to emphasize a few areas because, as many of you know, that this system we work under is somewhat resistant to change. That includes not only hospitals and administrative people, but also physicians. In fact, the physicians might be just about the most resistant to change, new thought processes. So what we're going to be doing is talking about 3 different areas of advancement. I'm going to talk a little bit about Barrett's and mucosal resections. Dr. Lamb is going to talk about ESD. He'll actually tell you what that is. It's one of the objectives. And Dr. Moosavi is going to talk about motility, so that you have at least an understanding of what these areas are. At the completion, you should know who to screen for Barrett's esophagus from my talk, know what ESD is and where it's developing through Dr. Lamb, and as far as motility studies, just have an idea of what it is. Not necessarily a lot more than that, but that's our objective. So I'm going to start a little bit with Barrett's esophagus, and then who's going second? Dr. Lamb will go second, and Dr. Moosavi will go third, and we should finish hopefully ahead of time so that we can entertain questions or comments. So who to screen? Our outline is fourfold. Who to screen? We've got to define what exactly is Barrett's, and then we've got to talk about what's the risk of Barrett's. I mean, who really cares? And then endoscopic mucosal resections and ablative techniques. I'll talk mostly about EMR, as that's probably the key endoscopic change that's occurred the past decade or so. So 45-year-old female with heartburn in the last 5 years, controlled on a once-daily PPI. Diet seems reasonable. Patient's not overweight, doesn't use excessive alcohol, is non-smoker. Physical exam unremarkable. What about endoscopy for Barrett's esophagus? This is a pretty classic consult. We would get sent this pretty routinely. And the question is what to do with this. And so there are, fortunately, guidelines to go by. When we screen for Barrett's esophagus, and I'll define Barrett's in a couple of minutes, screening for Barrett's be considered primarily in men with chronic greater than 5 years, and frequent means weekly or more symptoms of gastroesophageal reflux. But not just that. Ideally, there are some risk factors for Barrett's esophagus we look at. So it's not just somebody who has a little bit of heartburn on and off for a decade or so. So the other risk factors we look for are generally age greater than 50, generally Caucasian, Asians, Middle East do not get much Barrett's esophagus. I was speaking about Barrett's esophagus in the Middle East a few weeks ago, they have no idea what you're talking about. And the presence of central obesity, that's apple-shaped, not pear-shaped, and current history of smoking, and or a confirmed family history of Barrett's esophagus or esophageal adenocarcinoma in a first-degree relative. So that kind of gives you an idea of who we're looking at, not just somebody with some bloating, not just somebody with some stomach pain. Primarily, this is heartburn. That's a very simple subjective complaint of discomfort arising from the epigastrium going up towards the oropharynx, typically associated with empty stomach or other other exacerbating and relieving factors which you're familiar with. And that tends to be very intermittent. Given the lower risk of esophageal adenocarcinoma in females, screening for Barrett's esophagus in females is generally not recommended. So this is an American College of Gastroenterology guideline, and of course you always leave yourself a way out. Screening could be considered with the presence of multiple risk factors as outlined above. And so you've left yourself a door that's open. And this is always a challenge when you're sitting face-to-face in front of a patient. It's an easy discussion on paper that in general women don't get a lot of adenocarcinoma of the esophagus. In general they don't, but as we discussed this morning at rounds, a 50-year-old female, very similar to what I presented, in fact did have an advanced adenocarcinoma with Barrett, so it does occur. So you have to kind of risk stratify, particularly to prioritize patients accordingly. So, and what is the patient's perception? And this is probably one of the most difficult things in GI. It does seem like everybody we see is absolutely convinced that they've got something terrible. So if you survey a group of patients with Barrett's esophagus, they perceive their risk up to 20% over 10 years. In other words, 1 out of 5, they think that 1 out of 5 is going to die over the next 10 years of esophageal adenocarcinoma. And the majority of them actually accept endoscopic methods with 70% success, and the majority actually accept complication rates of up to 30%. So these patients are actually perfect for invasive testing because they'll accept anything. But the problem is Barrett's is not a high-risk issue. So the patients are begging for it, but when you actually look at what's the real risk, this is a prospective study that looked at patients for about 5.5 years with Barrett's. And the key number to look at here is probably the risk of developing adenocarcinoma, which is the concern in Barrett's esophagus, is about 1 in 200 per year. So the patient has Barrett's, their risk of progression to high-grade dysplasia / adenocarcinoma is about 1 in 200 per year. So almost the first thing you can tell every patient who's been diagnosed with Barrett's is they are much more likely to die of many other things than they are to die of their Barrett's esophagus. And so that kind of puts it in perspective a little bit. 1 out of 200, most patients say, oh, that doesn't sound that bad. It's still significantly higher than the general population, but this is a disorder that is not particularly high risk. What is it? It's an extension of pink mucosa in the esophagus extending greater than 1 centimeter proximal to the GE junction. Endoscopic biopsy should be performed. And in the presence, typically, of goblet cells, we have specialized intestinal metaplasia. We use a Prague classification, continuous Barrett's. You can see the pink stuff coming up into the squamous mucosa, 2 centimeters of continuous Barrett's above the line of the stomach or the gastric folds. And then the M is the maximal extent of the Barrett's, which typically we refer to as tongues. There's a C2, M5, 2 centimeters of continuous or circumferential, and 5 centimeters of mucosal extent. So we can show this short video which outlines a patient with Barrett's. You see just a few patches. The squamous is the white, that's normal, and the white should extend all the way down to the stomach, which is actually in the distance. I don't even think I'm going to show the gastric folds. But these pink patches, if you biopsy them, are specialized intestinal metaplasia, and that is, in fact, Barrett's esophagus. And so here we're going, you can see the gastric fold on your left. So that would be the native, and if you just go up and measure proximal to that is where we get our measurements from. The location of the various markers are important. and a number of biopsies in general, 4-quadrant every 2 centimeters are recommended. So I probably see 2 or 3 patients a year that have been biopsied by somebody else, and the patient has actually read the guidelines, because it's not real hard to find guidelines for patients, and they come to me and say, so-and-so did my biopsies, and they didn't take enough. They didn't do it right, which is very interesting, because patients now are very empowered. It's not hard to take biopsies. It takes you about 60 seconds to probably take 4 biopsies, maybe 8 biopsies if you're really quick. So it doesn't take very long, so you want to do these right if you're going to do it. What are the risk factors for progression? This is a longitudinal study at 5 centers. If you're male, if you have a long segment of Barrett's esophagus, if at the beginning there are some abnormal cells, i.e. low-grade dysplasia, and if you're a smoker. So now we can risk stratify even more. We look at, first of all, who should we screen? Males over the age of 50, generally obese, positive family history, with a long history of heartburn. And then if they have Barrett's, the ones we really want to focus on, longer segments, any evidence of low-grade dysplasia, male again, and smokers. So lastly, what can we do with Barrett's that progresses? Now remember, I said it progresses at a rate of 1 in 200. It's a very small group. It's a group that I tend to see, and so sometimes it seems like a lot of patients, but it's not. The group that we want to deal with endoscopically are going to be those T1 lesions that are just extending into the superficial aspect of the submucosa. So ideally, T1 intramucosal, and T1s that go into the submucosa. SM1 is the outermost, the first third. Once it gets beyond the first third of the submucosa, lymph node involvement starts to be more common. So that's when we want to get to this. Once it gets more advanced, i.e. T2s, T3s, or even a late stage T1, a deep T1, lymph node metastases are quite common, and in those patients, surgical intervention, other forms of therapy are certainly required. So what do we do with nodules? Nodules and dysplasia, as mentioned, are uncommon, but we want to remove them. We want to remove the nodule and then get rid of the Barrett's only in those patients with dysplasia. We don't do this to all patients with Barrett's esophagus, just those with dysplasia. Other patients are just monitored, surveyed, typically every 3 to 5 years, very much like your standard pap smears, where you follow patients at a certain interval. If they have high risk, i.e. low-grade dysplasia or indeterminate, you follow them in a shorter interval. But this would now be like a class 4. You're going to be very aggressive with endoscopic treatment. So this is how we burn it, and I'm not going to show any videos on burning. If there's a nodule, we remove the nodule, and then we burn the rest of the Barrett's esophagus. Just like the example I use is cryotherapy. Patients are all familiar with putting cryotherapy on a wart. It bubbles up, it falls off, wart gone, sometimes comes back. Same thing with this. We burn it, circumferential balloon. It ablates the Barrett's, it sloughs, it gives them some pain for a few days, and the squamous mucosa replaces it. And so that's one method, but we don't use that for nodules. For nodules, we tend to remove them, and this is endoscopic mucosal resection. So we remove the nodule first. So you can see I've got a little bander on. It's the same type of bander you actually use for hemorrhoids. Here I find I've already spotted the area that I believe is abnormal, and it's kind of flat, so we can't pass a lasso around flat things. So what we're going to do is we're going to suck it into the bander, and we're going to create a polyp. Once we create a polyp, we all know what to do with a polyp. Then it becomes easy. But because it's flat at the beginning, this is a slightly nodular area. So I've sucked it up to the bander. There's a little tripwire. I turn. It deploys a band, which you will now see. This is all real time, by the way. And now I've got my polyp, and we know what to do with a polyp. We're going to pass a snare around the polyp. You can actually look at the polyp to make sure you got the area you wanted. If you look at the head of the polyp, you can see that it's exactly the area that you want. And so now we're passing a snare down, which should come down in about 10, 15 seconds. I'm poking around, taking a look, make sure everything else is okay. And then I'm going to try to grab it just below the band. And when I grab it below the band, I will subsequently remove it with cautery. And then when I've got this piece removed, I've already scouted out my second set that I want to take off. And my second piece will be right beside this one. So I describe it as using a pitching wedge. And if you watch the pros do it, they pitch out one chunk of grass, and then they go right beside it, the next chunk of grass, and you can chip out the grass just perfectly, so you're trying to skin the distal esophagus. So you'll see here, this is the first chip. So this is one chip, and then we're going to try another one right beside it, which I won't show. And some patients will have a lesion that will require 3 or 4 chips. Everybody has different sized lesions. In this one, you're going to get one quick glance of it on your right, and then I'm going to suck up the piece and take it out. So that piece is out. With that piece out, we move on to the next piece and can remove, let's go back one, and can remove as many as we need to, generally less than 6. The bander actually has 6 bands on it. And then what happens is we take those pieces and we histologically analyze them. And if they show a deeply invasive cancer, the patient is now staged, because this is a staging maneuver as well. If it shows the intramucosal cancer, then the patient can actually be managed endoscopically, never needs to actually be referred to the cancer agency or even seen surgically. They would be managed endoscopically. This can be therapeutic. You've removed the cancer, but it can also be diagnostic. It demonstrates the depth of the cancer. And if it's too deep, then the patient usually goes on to surgery because of the risk of lymph node disease. Following this, if this is curative, we remove the nodules, we ablate the rest of the esophagus. Again, this is only in patients with dysplasia. We don't do this to the average patient with Barrett's, because the average patient with Barrett's only has a 1 in 200 risk of progression. So this is just dealing with the group that's 1 in 200 already advanced. And I'll stop there. That's endoscopic mucosal resection, EMR. We've discussed who to screen. We've discussed how to screen with appropriate biopsy techniques. And we've discussed what to do with dysplasia, particularly for nodules, and then for the rest of the Barrett's with ablation. Dr. Lamb's going to move on to discuss ESD, and he'll tell you what that is.
Thanks, Rob. Okay, thanks, Rob. Yeah. All right, so certainly, thanks, Rob. Certainly in the esophagus, EMR is very well established in terms of resecting superficial tumors of the esophagus. There has been just a different approach for other areas of the gastrointestinal tract. Specifically, what I'm going to talk about is endoscopic submucosal dissection of the stomach. Now, this, in theory, can occur in any area of the gastrointestinal tract to resect superficial tumors of the GI tract. But I'm going to stick with the stomach. Okay, and so the question really is who might benefit from endoscopic submucosal dissection, and really want everybody to appreciate what patients are at risk for developing early gastric cancer. And what I mean by early gastric cancer is gastric cancer that does not go beyond T2 stage, and we'll take a look at those pictures there. And also describes the risks involved with an endoscopic submucosal dissection. So ESD and EMR are two, just keep in mind, 2 resectional techniques in GI. So gastric cancer epidemiology worldwide, it's a very common cancer, especially in Asia, Japan, China, and South Korea. And if we take a look at what the age standardized incidence rates in Eastern Asia, it's quite a bit higher than that of Canada. 28 per 100,000 in men, and in Canada, probably a little bit less than half that amount or that incident rate. And in BC, although we do have a big immigrant population, which are from East Asia, our rates are somewhat a little bit less than that of Canada, and maybe because of healthier living. I'd like to think that's the reason why. But what's important to know is that in East Asia, they have well-established surveillance programs. So primary surveillance programs for gastric cancer. And here in Canada, if we take a look at the Canadian cancer statistics last year, we'll see that here, if we see stomach cancer here, and this is the stages in which it's detected at diagnosis, we see that stomach cancer, very few of them are stage 1 or very early cancers. Many of them are already stage 4 with metastatic disease. And so this actually leaves a big hole in our healthcare delivery, in that we detect some people with early stomach cancer, but we don't really know what to do with them other than surgery. So once again, detection of early gastric cancer in Asia is due to dedicated and coordinated screening programs. A lot of it is suggested because of the rates of Helicobacter pylori are a lot higher in East Asia than it is in Canada. And they find these early gastric cancers. Endoscopically, they take a look at it, the crypt patterns of the endoscopy to say that, this is a cancer here, and it's really well worked out. In North America, we detect early gastric cancer because of incidental findings. So if we're scoping somebody for Barrett's, reflux, screening for varices, dyspepsia, sometimes we come across these early lesions that have yet not been invasive. And in Asia, what they do is that they centralize their therapy as well. So if somebody detects an early gastric cancer, in South Korea, they tend to refer to a select number of tertiary care centers within the city. But in Japan, what they do is that they feed them into 3 national cancer centers, one in the north, one in the south, and one in Tokyo. And then they have endoscopists that just do ESD. And in fact, only just do ESD in specific areas of the GI tract. So an ESD of the esophagus is done by one group of people, which is different than the ESD people that do it for the stomach. So it's very, very specialized. What happens in BC? Well, before the introduction of ESD here and at VGH, we come across these early lesions and take a biopsy of it, find out that it's dysplastic lesion, maybe even high-grade dysplasia. And then we figure, okay, something needs to be done about it. A standard polypectomy is done, right? And you basically hope that you get all of it. People are brought back for more biopsies, and not uncommonly, they'll have dysplastic tissue still present. And then they go for surgery. Now, if you think about it, it's a fairly early lesion, not yet turned to cancer, yet they're going for basically organ-destroying therapy, which is surgery. Okay. After the introduction of ESD, unfortunately, we get referrals of lesions that have been removed several times, and then you got this lesion here, which you can tell, you can just see the scar tissue underneath this lesion here. So what are the indications for ESD? So much the same as EMR. We generally would like to see lesions that are fairly superficial. So carcinoma in situ for sure, T1, and also submucosal, superficial submucosal involvement. Right? And the reason is because with ESD, we go all the way down to the muscularis propria and resect the entire submucosa, and the goal is to get the lesion all in one piece for histological assessment. Okay. People who are higher risk for surgical procedures such as gastrectomy and if they've got an early lesion, are actually prime candidates for ESD, mainly because after gastrectomy there are potential complications and morbidity associated with the surgery that usually an ESD is attempted first before needing to go to surgery. So what are the high-risk populations? Well, ethnicity here in BC, East Asian, Russian, South American, and these actually mirror the prevalence of Helicobacter pylori around the world. Once you have Helicobacter pylori for a long period of time, you can end up with a destruction of the acid-producing cells within the lining of the stomach, and you get a condition called atrophic gastritis, which is a higher risk condition for developing a dysplasia. So whenever we see somebody with intestinal metaplasia or atrophic gastritis, and they're Helicobacter pylori positive, the best thing that you can do to prevent cancer is actually to treat their HP. Then there's other familial histories of gastric cancer. This one, I'm not sure if many people have seen this, but CDH1 gene mutations. This usually, or this is an autosomal dominant condition where every generation is affected by gastric cancer. And the risk of gastric cancer is close to about 80%. So it's not really a situation of when are you going to get your gastrectomy, but if they have this family history, it's have you sorted everything out before you get your gastrectomy. It's not if you're going to get it, it's when. Okay. H. pylori associated gastric cancer is presents as a different type of gastric cancer. It is of an intestinal type, and these cancers are typically located in the antrum and along the lesser curvature. Once again, the distribution of HP in the stomach. Okay? And it's interesting to note that the prevalence risk of immigrants coming to Canada mirrors that of the general population in Canada after one generation here in Canada. So I just want to highlight intestinal metaplasia is something that you can see after long-standing Helicobacter pylori infection. And these changes are associated with the fact that it's destruction of the acid-producing cells. You get a relative hypochlorhydria within the stomach, and then the mucosa gets replaced with intestinal metaplasia, which then has a risk for developing dysplasia. And this is what's shown out in this recent article. Okay, so the question is, if we find gastric cancer, do we necessarily have to remove it? Well, I mean, if we have ESD, it's fairly non-invasive, right? Usually people come in for the procedure. Right now, as we're doing them, I do them in the operating room under general anesthetic because I don't want them to move. But in other places in Japan and in South Korea, it's done by intravenous sedation. And people typically stay overnight and then go home, but they could easily go spend a couple of hours in hospital after the resection and then go home. So, but the question is should every lesion be that is detected be removed? And you really have to take a look at the patient themselves, right? Because if they do have a dysplastic early gastric cancer, right, it is estimated that it takes about 3.7 years to progress into an invasive malignancy, and then an additional 2 years to develop lymph node metastases. So if somebody you're seeing in front of you for an assessment for ESD, that they're not going to survive 5 years, right? It's probably something that does not need to be removed. Another interesting point is that, and this is sometimes what we find when we do remove these early gastric cancers and find that they're very deep, down to like a T1B, so still submucosal, there is a risk of lymph node metastasis of about 10%. And if people are of fairly good physiologic state, yes, they would go on to surgery and lymph node harvest. But if they're not, right, then 10% risk for lymph node metastases is actually not a bad rate. Okay. Other areas of the GI tract where ESD is useful, which I won't touch on, right, is esophageal, squamous, and adenocarcinoma. And this might seem like a direct competition with Dr. Enns' EMR, right? But it's interesting that ESD never really developed in the Barrett's adenocarcinomas space. And the reason is because this technique is developed in East Asia, and once again, they don't get Barrett's and they don't get adenocarcinoma. They get squamous cell carcinoma way more, right? The Japanese are very good at removing squamous cell carcinoma, but really they've not seen Barrett's esophagus. Right? I was actually doing some training in Japan, right? And I was speaking to one of the premier esophageal ESD patient, physicians there. And then he asked me about Barrett's esophagus and how common adenocarcinoma is, right? And then I say, oh, it's very common. And then he said, oh, I've got one patient. And he's a Caucasian from the U.S., right? so they rarely do see it, okay? Rectal ESD, I just wanted to mention something about this, is that the surgeons do have transanal techniques, but when it comes down to an adenoma that's down to the dentate line, it's sometimes very difficult to resect these lesions because the trocar that they put in the anal canal sometimes will block their view. And so a flexible endoscope is ideal for resecting the very distal margin of the dentate line. And so that's what we've been doing here as well. And less useful areas, right-sided lesions of the colon, mainly because the alternative is a right hemicolectomy with a 3% complication rate. It's hard to justify doing ESD, which takes a little bit longer, and then there's a higher risk of perforation. And of course, the duodenum is always a less useful area because of very high risk of perforation. So I'm just going to show you the ESD video of one in the stomach here. And this will just outline the procedure itself. So this man here presented with an iron deficiency anemia and had an endoscope in Burnaby Hospital and was found to have this hyperplastic polyp. But the biopsies did show signs of dysplasia. So he was referred for an ESD. So what we do is we take a look at this lesion carefully to look for any other worrisome signs like deep invasive disease. And because of the whole process of ESD, you might lose where you're going to go. The first point to do is to mark the area around the lesion or mark the perimeter of the lesion. Okay? And then the next thing is to inject some fluid, and in this case it's hydroxyethyl starch with some methylene blue. And what that does is it raises the submucosa, makes the submucosa a bit thicker. And so as we enter with the knife, we can actually see the muscle layer and also see where the mucosa is. And so here, this is the initial incision of the ESD. And you can see here that there's this blue clear stuff. That's all submucosa. That's all submucosal fat, right? And then underneath, you can get a sense that there's a bit of a whiteness. And this whiteness is the muscularis propria of the stomach. And so as we enter into the submucosal space, the fat is essentially melted with the cautery as we go through. Ideally, you can see on the end of the endoscope here, there's a little plastic rim around it, and what that does is that it helps to deflect the specimen away from the resection field. And of course, in the submucosa, that's where we see most of these submucosal vessels. And as we go along, we cauterize them and cut them. And afterwards, I'll show you a little bit later, but afterwards, we make sure that these submucosal vessels are in fact cauterized before we pull the scope. Okay. So, and here's the last shot is that after the last bit is removed, you end up basically with a big ulcer. Okay, and we take a look at the bed of the ulcer, look for persistent blood vessels that we have forceps to cauterize, and the bleed rate is fairly low. Right, I usually keep people on IV PPI overnight and see what they are like the next day. Most of the time, they're on clear fluids right after the procedure, and that's the lesion. Looks somewhat anticlimactic. It looks kind of small, but it's actually about took a long time. It took about 2 to 3 centimeters. Thank you. So, Sarvee. Oh, yeah.
So now we've done EMR, endoscopic mucosal resection, ESD, endoscopic submucosal dissection. Both aimed at the surgical side of things. There's also ESD, as Dr. Lam mentioned, in the esophagus, which there's various maneuvers for achalasia as well. And that kind of brings us to a more diagnostic phase. Dr. Moosavi has recently completed training in motility, and this is one of our goals for this year, which is rapidly, I guess the year is rapidly coming to a close, is to set up motility. And so she's going to discuss motility, its uses and benefits. Thanks, Sarvee.
Thanks. So I'm going to talk in the next 15 to 20 minutes quickly about some of the GI motility and functional evaluation. I thought it would be appropriate to talk about the workup of dysphagia in order to introduce esophageal functional evaluations with esophageal manometry and pH monitoring, and I'll touch upon chronic constipation to discuss anorectal manometry briefly. So symptoms related to abnormal GI motility and functions are quite common, and dysphagia, heartburn, bloating, abdominal pain, and change in the bowel habit accounts for almost the majority of the referrals we get to internal medicine and GI. And the prevalence of GERD, functional dyspepsia, and irritable bowel syndrome is anywhere between 5 to 15%. The symptoms of the functional GI disorders are quite non-specific, and there's really no specific diagnostic test that if it becomes positive, you say this patient has functional GI disorders. And also the treatments are not particularly specific, and we have limited access to multidisciplinary approach, especially with psychiatry, psychologists, and chronic pain management, which obviously makes the disease management quite challenging. However, there are advances in the field which allows us to assess the GI function and motility, and that has driven our understanding of these conditions a bit better. When you see these patients, I think it's really important not to get narrow-minded. We always roll our eyes and say another abdominal bloating, but I think it's really important to actually take an appropriate history. And however you approach it, whether it's systemically, essentially mouth to anus, so it's important to ask about dysphagia, heartburn, regurgitations, chest pain, dyspepsia, nausea, vomiting, abdominal bloating, and change in the bowel habit. And essentially, we know that there are some features that differentiate between the functional disorders and organic causes. Often, but not always, these patients are younger, particularly younger than the age of 45. I guess if I say that they're most common in women, it sounds less sexist, but it is more common in women, and particularly in white populations. And often the onset of the symptoms are poorly defined, so they usually have these symptoms for several years. And they do have other functional syndromes as well, including interstitial cystitis, fibromyalgia, chronic pain. And they have often seen multiple specialists and have had multiple diagnostic tests, and they self-report poor response to various therapy. And often both physicians and patients are quite unsatisfied and frustrated with the diagnosis and the outcome, owing to the non-specific nature of the symptoms and lack of specific and effective treatment and diagnostic test. So in approaching these patients, again, the first step is to ensure that they do not have any alarm features. Those include dysphagia, anemia, unintentional weight loss, particularly more than 5% of their baseline body weight, and symptoms suggestive of GI bleed, abdominal mass, or lymphadenopathy, and especially if there has been some change in their symptoms, particularly if they're older than the age of 45. And the presence of alarm symptoms are often associated with 5 to 10% risk of life-threatening diseases, as opposed to 1 to 2% when these symptoms do not exist. And in the absence of red flag symptoms, perhaps it's not necessary to jump to doing another colonoscopy, other investigation, invasive investigation, especially if they've had several of them already. There are certain criteria that you can use, with the most updated one, Rome 4 criteria, that allows you to classify these pushing on something, functional GI disorders to see whether there is any symptoms for the last 3 months or in the past 6 months before that suggests that these patients do meet the criteria for functional GI disorders in the absence of other diseases, as long as the appropriate limited investigations are ordered. So there are tests that we can assess the GI motility. Now, whether we have access to these investigations or not, that's a different question. But we do have access to modified barium swallow, which I'm going to talk a little bit about more. And we're hoping to get the esophageal manometry and impedance with pH monitoring that allows us to assess the function of the esophagus. And other tests for the rest of the GI tract, including gastric emptying study. And in some centers, they have SmartPill, which allows the assessment of gastric emptying as well as the rest of the GI tract. We do have access to radio-opaque markers, the colonic transit studies, which allows us to rule out essentially slow gut transit or normal transit constipation, and also the anorectal assessment with anorectal manometry, balloon expulsion, and we have access to barium defecography. So in approach to dysphagia, I think it's the first question you want to ask is that whether this is oropharyngeal dysphagia or esophageal dysphagia, because the workup is a bit different. I mean, patients with oropharyngeal dysphagia, you often encounter those in more elderly patients. They report symptoms of difficulty with initiating swallowing. They have choking, coughing, recurrent aspiration, and even sometimes nasal regurgitation. And they often localize their symptoms to higher neck or in the throat. And these are the patients who have often anatomical or neuromuscular abnormalities. And this is just a limited list of some of those differentials, including Zenker's diverticulum and oropharyngeal malignancy, and neuromuscular disorders such as CVA, significant dementia, Parkinson's, and muscular disorders such as myasthenia gravis and muscular dystrophy. So these are the patients that often are evaluated with video fluoroscopic swallowing examination. On the other hand, if they have symptoms that are more suggestive of structural abnormalities or underlying esophageal dysmotility, where they report foods getting stuck retrosternally or the regurgitating, they complain about chest pain, you often start with upper endoscopy. And in some cases, we also do barium swallowing. And then if the symptoms persist, that takes you to esophageal manometry to assess motility. You also want to ask whether the symptoms are with solid only or if it's solid and liquid. The patients who endorse symptoms predominantly with solid are more likely to have structural abnormalities. And you also want to ask about the timeline, so that has been going on intermittently or if it's been more of a progressive type presentation. So in patients who have intermittent symptoms, you often have esophageal rings or webs. And if they're a younger man in their 30s and 40s with history of atopy, you always wonder about eosinophilic esophagitis, which requires the biopsy from proximal and distal esophagus to rule out this diagnosis. On the other hand, if they have progressive symptoms, and they're older individuals with significant weight loss, then you worry about malignancy. However, if they've symptoms been going on for years with slow progression and chronic heartburn, then that may be due to the complication from underlying reflux disease, including stricture esophagitis. If they have symptoms with both solid and liquid, they're more likely to have underlying esophageal dysmotility as long as you rule out structural abnormalities. And depending on some of the ancillary symptoms that they may have different types of esophageal dysmotility, but you often require to have esophageal manometry to figure out what kind of esophageal dysmotility they have. So that brings me to the discussion of esophageal manometry. Just to briefly introduce it, so it's actually a catheter-based test where the catheter has multiple pressure sensors along its length, and it's inserted through the nose, and often the patients are gagging and coughing during the insertion, so I'm not sure if this patient is actually awake or not. But anyway, so they have to be awake to be able to follow the instructions. And you ask the patients to take 10 swallows. Often we use just a small bolus of normal saline. But in order to elicit certain symptoms, then we might actually choose to give viscous fluid or even solid food. And you get this esophageal pressure topography with color contour on the computer. And there's certain pattern recognition you have and also certain criteria based on the Chicago classification that you would be able to categorize different esophageal dysmotility. So as part of the workup of non-obstructive dysphagia, after you do your upper endoscopy barium swallow, if the symptoms persist, the next step is to obtain esophageal manometry, particularly if you suspect that there's a diagnosis of major motility disorders such as achalasia. We also have a big scleroderma population at St. Paul's, and 95% of these patients have esophageal involvement. So after you do your upper endoscopy, you control their acid reflux to the best of your ability. If their symptoms persist, they require to have esophageal manometry. In addition, patients who are considered for anti-reflux surgeries, they're required to have esophageal manometry and pH monitoring as part of the pre-op workup, because that does give you information about the size of the hiatal hernia and other features of esophageal junction that dictate the type of the surgery. And if they're going for pH monitoring, they have to have esophageal manometry because you need to manometrically assess where the LES is located to place the pH monitor, the tip of the catheter 5 centimeters above that. We briefly talked about GERD. by definition, is the reflux of stomach content that causes troublesome symptoms and or complications. And about 10% of the general population does experience heartburn or acid regurgitation, so classic symptoms of it at least 2 to 3 times a week. In the absence of any red flag symptoms, these patients are started on antisecretory therapy with H2 blockers or PPI, and we talked about some of the indications for upper endoscopy, including Barrett's surveillance. So the question is, why bother with further workup? We know that when we diagnosed GERD based on certain questionnaires or by GPs or GIs, we actually have sensitivity specificity around 60 to 70% when it's compared with catheter-based pH monitoring. Now, by no means I don't endorse that every single patient with GERD has to have a catheter-based evaluation, but there are certain indications for that. And the studies have shown heartburn and acid regurgitation are present in only about 50% of the patients with pathologic reflux. On the other hand, about 23% of the patients who did have pH monitoring actually had normal evaluation, but they did have symptoms of heartburn and regurgitation. And those are the patients that are more likely to have esophageal hypersensitivity and functional heartburn. And 70% of the patients with GERD and about 50% on non-GERD patients respond to PPI, so not everybody responds to PPI. So there's this notion of PPI non-responder GERD. So these are essentially patients that have adequately tried PPI. So that's the double dose PPI for a good 6 to 8 weeks, good compliance. They've taken the PPI appropriately, then they have persistent symptoms. So when you approach these patients, again, it's really important to approach them systematically, because there are other barrier mechanisms that are in place to make sure that patients don't have GERD symptoms. So patients with Sicca syndrome, they have xerostomia, and they may also have the impaired esophageal motility, which results in impaired bolus clearance, and as a result, they may have persistent symptoms. And no matter how much PPI you give that to them, it's not going to address that issue. And also, we have the any compromise of the gastroesophageal junction could result in persistent GERD symptoms, including frequent transient lower esophageal sphincter relaxation, hiatal hernia, and also downstream symptoms such as gastroparesis and constipation. And there's also the notion of the interplay between esophageal hypersensitivity and acid exposure. So if you're on the left side of the diagram, you're far more likely to respond to PPI therapy. However, in order to differentiate between NERD, which is a non-erosive reflux disease, reflux hypersensitivity, and functional heartburn, you do need to have pH monitoring to see whether there's any of their symptoms that does correlate with pathologic reflux, depending on the certain criteria on the pH monitoring. Because these patients, towards the functional heartburn, are very unlikely to respond to PPI therapy. And that's when you want to stop the unnecessary PPI and switch them to neuromodulator and also improve patient educations around their symptoms. So some of the indication for reflux monitoring include persistent typical symptoms of GERD despite adequate PPI therapy, and you haven't had any objective evidence that they do have pathologic GERD. That means Barrett's esophagus, severe reflux esophagitis, or other complications from their reflux, and they've never had pH monitoring before. And the notion of the atypical symptoms is actually a talk on its own, but really if they've had chest pain, chronic cough, and so on, and they've never been diagnosed with GERD objectively, again, you just want to get the pH monitoring to essentially rule out GERD as a potential cause of their symptoms, because a lot of times GERD gets the blame, but may not necessarily be the symptoms that is causing their chronic cough. And we talked about the functional heartburn and reflux hypersensitivity, and other etiologies such as aerophagia and rumination syndrome in conjunction with esophageal manometry needs pH monitoring. So just to briefly discuss, constipation, it has a high rate of prevalence of IBS in Canada, 1 in 7, with an incidence of 120,000 new cases a year. And again, history and physical examination is quite the important factor, including rectal exam, and you want to ask about rectal bleed, unintentional weight loss, and new symptoms older than the age of 40 to 45. And if that's the case, then you first do the colonoscopy. This was the algorithm that was published in Annals of Internal Medicine in 2015, that essentially tells you that you start with your history, and of course you do the ancillary test, and then you do the therapeutic trial with laxatives, generally with osmotic laxatives such as PEG-based laxatives or magnesium supplement plus or minus fiber. And then you reassess their symptom. If they have inadequate response, you actually want to rule out the anal outlet constipation first with anorectal manometry and balloon expulsion test. And if that is abnormal, and then they're more likely to have defecatory disorders, and these are the patients that do benefit immensely from biofeedback rather than laxatives after laxatives. And if that is normal, then you move on down the essentially management of the slow transit and normal transit constipation. So anorectal manometry is also a catheter-based test that has pressure sensors along the length of the catheter with a balloon attached the tip of it and centered into the rectum, and you ask the patient to essentially relax and to do certain maneuvers in order to evaluate the pressure abnormalities if there's anything suggestive of defecatory disorders. Now, the cheapest tool that is most readily available is actually your finger. So that gives you a lot more information that we actually give credit to. And this was a paper that was published by Satish Rao in American Journal of Gastroenterology in 2018 that reviews how appropriately you need to do the digital anorectal exam. And I think a lot of time when we do the rectal exam is just to lubricate the anus so we can insert the colonoscope, but that is not the way that you do rectal exam. Is actually this is an office-based evaluation. You ask the patient to be in the left lateral decubitus position. You do the inspection of the anus for any masses, excoriation, anal skin tag, and so on. And then you also assess the sensation of the perineum with a cotton bud, or essentially you break it and then you with a sharp test as well. And then you lubricate the finger, you insert it into the rectum, and then you're assessing the resting tone first. And then you ask the patient to squeeze around your finger with the anus up to 30 seconds because you want to see whether they're able to maintain that pressure. And then you palpate for any sphincter defect. Then you ask the patient to bear down, and you have to put your hand on the patient's abdomen to see whether they are able to actually generate adequate pressure. And you're looking to see if there's any paradoxical contractions of the puborectalis muscle in this anal sphincter, and also exaggerated perineal descent. So this is just a schematic presentation to show you what happens during dyssynergic defecation. So normally when you have your finger inserted and you ask the patient to bear down, you have the relaxation of the puborectalis muscle and anal sphincter muscle. But in patients who have paradoxical contraction, essentially the puborectalis muscle contracts paradoxically during the simulated bear down, and that pulls the rectum anteriorly. So you actually feel a little tug on the finger. So these are the patients that are benefit mostly from the biofeedback. So in conclusion, the symptoms have poor specificity for GI diagnosis. There's a marked overlap between organic diseases and functional GI disorders. There are new technologies that are available that have revolutionized the clinical measures of GI motility and function from oropharynx to anorectum, and the diagnosis should be based on valid objective metrics, including Chicago classification for esophageal motility and other tests that we have that assesses the motility of the GI system. And Rome-4 criteria are there to classify the functional GI disorders based on presence of specific digestive symptoms for at least 3 months out of 6 months before the diagnosis in the absence of other diseases on appropriate investigations. And it's important to realize that there is abnormal visceral sensitivity in this patient population, and often you have overlap with other psychiatric disorders and psychosocial stressors, but it is important to note that these disorders are not in patients' head, nor the diagnosis of exclusion, so they do need to meet certain criteria. But unfortunately, we do have limited access to these motility studies and a multidisciplinary approach, which makes the management of these patients challenge. But hopefully, we can have the motility lab going on. Thank you.
So yes, Joni. So what we've summed up is EMR and assessment of Barrett's esophagus, first of all. Then we moved to ESD, endoscopic submucosal dissection, stressing kind of the technical surgical aspects. And lastly, we moved to almost the opposite of diagnostic maneuvers for functional bowel disease, which is typically non-surgical. And so these are 3 advances that have developed the past probably decade or so, and motility is not fully developed yet. The other areas are getting there. And so we'll be happy to entertain questions or comments. Oh, yes.
Thank you so much for your nice presentation. In my country, I rarely see long segment body. Usually have ultra short or short segment body. With respect to this fact that the progression from Barrett's esophagus to malignancy is depends on the length do you recommend, is it different between long and short segment Barrett in frequency of the screening?
The question has to do with short segment Barrett's versus long segment Barrett's. Short segment generally defined as less than 2 to 3 centimeters, and the comment is that in certain countries, particularly the Middle East, they may see intermittent short segment Barrett's. And do those require as much surveillance? The typical surveillance of Barrett's esophagus is 4 quantum biopsies every 2 centimeters, and it's usually done every 3 to 5 years. Why 3 to 5 years? Well, the 5 years based on cost effectiveness analysis, and the 3 years based on what people think they should do. And so there's significant variation. And so when you look at patients, you have a little bit of wiggle room. And it is exactly what I do. I look at, well, is this male, is it female? They have Barrett's already. Is it long segment, is it short segment? Is there any family history? Is there anything that moves me towards a 3-year interval, which is a shorter interval? If it's a short segment, female, no family history, no obesity, no hiatus hernia, that would steer me closer towards a 5-year screening interval. So yes, in general, we think of short segment as slightly lower risk, but there's other factors that can be looked at with that. Other questions, comments? Thanks, guys. Have a good day.
Huh? No, I think the control is up. I think they. Yeah.
How did the table go down?
I don't know. No, I think somebody has control. I think so. Like somebody has control, and then you were like take right.
Oh, I was like, what am I touching? Let's go. That's what I thought. I thought I was touching this, but I'm like, that's not a pedal.
Yeah, there was no pedal, so I think somebody just adjusted.
Thanks to my height. Okay.
Hey, say it again. I'm away tomorrow and Monday. Yeah.
We're going to discuss tomorrow this.
And we yeah. And yeah.
I'm doing that.
It's like the chili bowl.
It's like they're GI. I mean, fairly involved. And that can be all part of
Well, actually,
I hope so.
Hello.
Well, what I think we do is make an appointment to see this and talk about the possibilities. So you can contact the office.
What was your office?
It's in the park. It's in the building and it's
Okay, thank you. Thank you.
be a functional body, so versus it's a lot of footage. It's a lot of drugs. Would be a
Urgent caring conditions.
true. I can't imagine. Practice.
Very happy.
Sorry we could do it.
Yeah.
I wasn't sure if they would call us when they found it. Okay, sure. Yeah. Okay, sure. Yeah, I'm teaching students, but other than that, sounds good. Thank you very much. Oh, no. Good. Lots of extras. How are you? I'm doing well. Yeah, how about you? I'm still doing my cheap track.
No, I know that some of the we discussed getting extra results.
Oh, I do clinic half an afternoon or one afternoon a week, and we have a patient who's had about a million different scans. And is convinced she has multiple myeloma because there was one comment on one scan the head that commented on something. She's got a negative aspect but no high calcium.
You're convinced, or she's
convinced. She's convinced. We are very much not convinced. So we asked the radiologist to just look at all of her scans and see if there's anything. She, I think she read, the comment was on the scan to exclude multiple myeloma.
Okay, yeah, I could see that. Right?
Yeah, totally.
Interpretation.
Yeah.
Yeah. Good. There's no different.
No, it's good. It's good to see you.
Okay, take care.
Hello, Tracy. Hello. December the 6th. What day of the week is that? Thursday as well. Okay. And what time would you have the morning would be better, actually. 9:30 would be great. Okay, and that's again in the hand clinic, or is that over at home? Okay, perfect. All right, December 6th, 9:30. I will be there. Thank you. Bye.